Welcome to today's webinar, Healthcare Waivers Part 2, brought to you by NCSL. It is now my pleasure to turn the floor over to Lisa Law. The floor is yours.
Thank you, and good morning, everyone. I'm Lisa Law with the NCSL Health Program, and on behalf of the National Conference of State Legislatures, I'd like to welcome all of you to today's webinar, Healthcare Waivers Part 2, which is a second in a two-part series for states on waiver opportunities. I'd like to remind participants that NCSL is a bipartisan membership organization of state legislatures. NCSL advocates for interests of states and provides policymakers with the opportunity to exchange ideas. This webinar is a platform for information exchange. We encourage a robust Q&A at the conclusion of the presentation and remind participants that they can ask questions at any time during the webinar. You can ask a question by entering it in the box located in the lower left-hand side of the screen. And before I introduce today's panel of speakers, I want to thank the Health Resources and Services Administration for their support of today's webinar. NCSL staff.
Good morning.
NCSL staff has received a number of requests for information and clarification of opportunities for states related to 1332 federal healthcare waivers. With us today is Representative Jim Dunnigan, the co-chair of NCSL's Health and Human Services Committee and Majority Leader in the Utah House of Representatives. Representative Dunnigan will introduce our speakers for today. So I'll turn it over to you, Representative Dunnigan.
Thank you, Lisa. Good afternoon. I want to thank NCSL for arranging this opportunity for state policymakers to learn more about the opportunities for states through the 1332 federal healthcare waivers. All of us are very aware of the potential for innovation through waiver opportunities. As a legislator, I'm also all too aware that controlling healthcare spending remained one of the biggest challenges for states. Beginning January 1st, 2017, which is just right around the corner, a new state option within the Affordable Care Act will take effect, known as Section 1332 waivers. For the first time since the law was signed 6 years ago, this new process provides states with an opportunity to design a new coverage system customized for their local context and preferences, while still fulfilling the aims of the ACA. The statute requires interested states to pass authorizing legislation as an early step in order to apply for and ultimately implement waiver-based reforms. As of summer 2016, at least 15 states have considered legislation to kickstart the waiver application process. The content and proposed state changes vary widely, from minor fixes to substantial redirections. Some states seek to restrict the use of these federal waivers, and some early measures have been defeated or deferred. This webinar provides us with an opportunity to hear from two national figures who have key expertise in this area and can give us further perspective on the proposed Section 1332 waivers. And I'd like to introduce our two key figures. We have Cindy Mann. She's a partner at Manat, Phelps & Phillips. She works with clients to develop and implement strategies around federal and state health reform, Medicaid, the Children's Health Insurance Program, and delivery and payment system transformation. Her clients include states, providers, plans, consumer organizations, and foundations. Before joining Manat, Cindy was with the Centers for Medicare and Medicaid Services. There, she served as Deputy Administrator and Director of the Center for Medicaid and CHIP Services. Cindy led the administration of Medicaid, CHIP, and the Basic Health Program for more than 5 years during the implementation of the Affordable Care Act. She set federal policy, supported state program operations, and coordinated policy and program operations within the marketplace. During her time at CMS, we at NCSL benefited from her participation in many of our meetings and discussions. Along with her, we have Patricia Buzang. She advises states on Medicaid expansion design, implementation, and sustainability, and has particular expertise in alternative expansion models through 1115 waivers. For Arkansas, she helped develop and implement the state's groundbreaking private option initiative and its successor program, Arkansas Works. As a technical assistant expert in Robert Wood Johnson's Foundation State Health Reform Assistance Network, Patricia counsels states on the Affordable Care Act, most recently leading the Foundation's State Network 1332 Waivers Affinity Group. Thank you both for being with us today. Cindy, I'll turn it over to you.
Thank you very much, Representative Dunnigan, and it's a pleasure to be here again with NCSL and with all of you today. As the representative said, we are going to do today a deeper dive into Section 1332 waivers. At the webinar we had last week, just to give everybody a context of 1332 waivers and where they fit into the spectrum of available flexibility for states around healthcare. Last time we talked about first starting a discussion about what states can do in the Medicaid program without a waiver. How do you think about whether you do or don't need or want a waiver, and what other authorities might be available to states to achieve the objectives that they might want to undertake. We then talked a bit about the basics of 3 different kinds of healthcare waivers. One was Section 1115, which is the major comprehensive source of waiver authority in the Medicaid program. We also talked about 1915, which provides more targeted authority, waiver authority in Medicaid around managed care, home and community-based services. And we talked a bit about this waiver that we're doing the deeper dive today, 1332, the new healthcare waiver that Representative Dunnigan talked about. It's a new authority, as he noted, and NCSL has been getting a lot of questions about it and a lot of interest in it. So we're very happy today to go through with you what the basics are of the waiver authority and what some of the possibilities are that states could contemplate under 1332, and to give a sense right now, as early picture of where the state activity is around 1332. So I'm going to start off around the basics and then turn it over to my colleague, Patty Bouzang. So again, I think we wanted to start with the questions that we think are always pertinent as state elected officials, policymakers are thinking about waiver authority, which is not to start with digging into the waiver authority itself, but to start with what are my goals for the state, what program changes would enable those goals, and then looking at the question of what federal authorities might enable those desired changes. Let me give you an example. You might be worried about the breaks in coverage, churning, sometimes it's called, for people because you have the Medicaid program and the state children's health insurance program and the marketplace, and perhaps you're finding that there are issues of churning, of gaps in coverage as people's situations change in any particular direction that may make them eligible for one program and not for then for the other. So what do you do if you're interested in reducing that churning and making sure there's greater continuity of coverage? Well, one of the first places you might start is simply to make sure you have really good IT solutions to make those linkages happen smoothly for people, for consumers. And the Affordable Care Act provides some rules and some opportunities on that. But you might also go a step further and adopt a basic health program, which a couple of states have done, Minnesota and New York at this point. And that allows you to provide coverage through either an extension of the marketplace or extension of your Medicaid program up to 200% of poverty. So it helps reduce some of that churn. Or you might look at 1332, the waiver we're going to talk about today, and Section 1115. So the point here is really to think about what you're trying to achieve, and then it may be that there are no waiver authorities that you need, or there could be other kinds of authorities available, like in this case the basic health program, or in fact you may want to look for more sweeping changes, which you might find under the waiver authorities. So let me jump into 1332 and review the basics. As Representative Dunnigan said, this is a new waiver authority. It was created in the Affordable Care Act to give states additional flexibility beyond what the construct was in the Affordable Care Act. And as he noted, it is effective January 1, 2017. So nobody is yet operating under a 1332 waiver. But as my colleague Patty will talk about, we have a couple of states that are have pending requests, and as the representative noted several states where their state legislatures are considering 1332 and whether or not that's a route for healthcare reform in their state. So to get this waiver authority, it's a little bit different than Section 1115. Section 1115, the waiver authority for Medicaid, you go to the Secretary of HHS. For 1332, it's jointly from the Secretary of HHS and from the Treasury Department. And certain provisions of the ACA that we're going to go through are subject to that waiver authority. And it's joint between HHS and Treasury because the 1332 waiver authority potentially, depending upon how a state proceeds, will touch on issues around the premium tax credits or tax penalties, and so it's not just HHS authority, but brings in Treasury and IRS issues. And then third basic point that we really want to stress, because I think there's a lot of confusion out there, is 1332 is not a Medicaid waiver. So the Medicaid waiver authority is generally in Section 1115, the authority we talked a little bit about in our first webinar on the topic of waivers. And 1332 is really more about the small group individual market and some of the other non-Medicaid provisions in the Affordable Care Act that we're going to discuss. That being said, the law contemplates, and certainly some states are thinking about, doing 1332 waivers alongside a Medicaid waiver to achieve their policy goals, and we'll talk about some ways in which they can work together. So it's not a Medicaid waiver. If you are only thinking about a Medicaid waiver, then you should be thinking about 1115. And if you are thinking about a broader initiative that you might want to do across the continuum of the marketplace and Medicaid, you may want to think about combining 1115 and 1332 waivers together. Okay, I'm going to talk about what can be waived under 1332 and what's called guardrails. What are the constraints on those waiver authorities? So I just want to get that concept out first, that there are a number of ACA provisions that can be waived under 1332, some really very basic provisions of the Affordable Care Act around some of the coverage and tax issues. But there are also guardrails, meaning constraints within the law that say, yes, you can waive, but you also need to consider these other factors. So the example here is, let's imagine a state wants to use 1332 waiver to offer higher tax subsidies to make coverage more affordable. Perhaps they're looking at participation for people between 138% of poverty and 200 or 300% of poverty, and thinking that they want to deepen the subsidies that are now available through the premium tax credit. That is something that can be accomplished under 1332 waiver, but looking at the other side of the scale here, one of the guardrails is that the waiver under 1332, any 1332 waiver, cannot increase the federal deficit. In other words, it can't cost the federal government more than if you didn't do that waiver. And so you may need to make some other adjustments in your healthcare program in order to come out with budget neutrality for the federal government. So as we talk about what can be waived, we'll talk first about what can be waived, but then jump into some of those guardrails. So here's the list of the basic areas of waiver, and you'll see that they're quite broad and quite potentially sweeping. One is that states can use the 1332 authority to modify or eliminate tax penalties that are applicable for individuals who don't maintain health care coverage. This is commonly referred to as the individual mandate. The ACA requires individuals to have health insurance coverage and imposes tax penalties when they don't, unless they fall within certain exempted groups. And through 1332, a state could do away with or modify that individual mandate and the rules around the individual mandate. Similarly, a state can use 1332 authority to modify or eliminate what's referred to as the employer mandate, the requirement on large employers to provide affordable coverage to their full-time employees. So a state could go to 1332 and make some changes, or in fact even completely eliminate the employer mandate. Again, I remind you of the guardrails that are coming around the next slide. Third is a state can modify the rules around what benefits and subsidies are available to people in the individual and small group market through the marketplace or otherwise. And they might think about adding benefits. They may think about modifying different benefits. And through 1332, you could actually modify or even eliminate the qualified health plan certification, or even the utilization of the exchange as the vehicle for deciding eligibility and for enrolling consumers in coverage. So you could really come up with a very different way of making coverage available to people in your state. So as you can see, those are quite sweeping, potentially very broad opportunities to modify the various provisions in the Affordable Care Act. But the goal of 1332 is to allow these different routes to achieving coverage, but while not diluting the coverage that is otherwise guaranteed under the law. And so that's where the guardrails come in. So yes, lots of modification is possible, but still the law says you can change a lot of these rules, but we want to make sure that the bottom line guarantees of coverage, of affordability, of benefits remain in place. And so let me go through these guardrails. First is that the waiver, the 1332 waiver, with the modifications that you might propose, has to provide coverage to at least as many people as the ACA would have covered without the waiver. And that's showing that you're going to have to put forward if you're going in that direction, and one that HHS and Treasury would have to agree with and say, yep, I think you have not diluted coverage. You may be providing it in different ways, but in fact the same number of people as would have gotten coverage without the waiver will still get coverage with the waiver. Similarly, the 1332 waivers must assure that the coverage is at least as comprehensive as the coverage that would have been available through the exchange. So you might change the benefit package, for example. You may modify different ways in which the coverage is designed, but you need to make a showing to HHS and Treasury that it is at least as comprehensive as what people would get without the waiver on the exchange. And similarly, the third guardrail of this ilk is affordability. That, again, as you might recall, you can do waivers in 1332 of the subsidy provisions in the Affordable Care Act, but the waiver must assure that the coverage and cost-sharing protections, the out-of-pocket out-of-pocket cost protections, are at least as robust as they are on the exchange. In other words, you can change some of the rules of the game, but affordability has to be at the same or better under a 1332 waiver. The fourth is a little bit of a different one, and the one I mentioned a minute ago, which is that with all of these changes, the changes you can do and the guardrails that you need to abide by, the waiver in the end of the day can't be increasing the federal deficit. So you might be, increasing something over here, but you might be modifying something over there that overall would keep this budget neutral to the federal government. And again, that's a certification that HHS and Treasury would make based on the presentation that a state puts before them in their waiver proposal. I do want to note that last December, the Obama administration issued some guidance on 1332. There aren't yet substantive regulations. There's some regulations in play about how the waiver process will work, what a state needs to present to the to the feds, to HHS and to Treasury, what the review process will look like. But the regulations don't get into the components we just talked about, what can be waived and what the guardrails actually provide. And as you're reading these guardrails and these waiver authorities, I'm sure lots of questions come to mind. What HHS did do and Treasury together did do is issue not sub-regulatory guidance in December, and I think it's fair to say that those were that the guidance was pretty stringent in terms of how they interpreted these guardrails, and so it's another piece of information that you'll want to consult as you think about 1332 in your state. But we also want to flag that it's sub-regulatory guidance, and it very well may change under a new administration, or as any administration gets a little bit more experience with 1332 under their belt. Finally, I just want to mention that what a state cannot waive is non-discrimination provisions, provisions that don't allow carriers, insurance issuers to deny coverage or increase premiums based on medical history. No medical underwriting is allowed under the ACA, and this is not something that can be waived under 1332. So I'm going to turn the podium over, such as it is, the virtual podium, over to my colleague Patty Bouzang to talk a little bit more about, okay, given these waiver authorities, given these guardrails, what are some of the kinds of things one can do under 1332, and then we'll take a look at actual state activity. So Patty?
Great. Thanks, Cindy, and thanks, everybody. It's great to be here with you today. So I'm going to talk a little bit about what are some possibilities for states to use 1332 waivers to achieve their policy goals. What do we know about applications that have been submitted by states to date? And what else is out there in the hopper? What are some other states thinking about and working on with regard to 1332? And I just want to key off of a point that Cindy just made about the sub-regulatory guidance that came out about 1332. I think it's safe to say that because that guidance was somewhat stringent, it was somewhat discouraging to some states that were thinking about 1332 because it seemed that the administration was signaling that there was going to be a high bar, at least in this administration, for advancing 1332 waivers. So what we've seen in this last year out there among states is that states have been using 2016, those states that are thinking about 1332 have been using 2016 as more of sort of a planning and a thinking year, really doing the work around what's happening in our coverage market, in our health insurance market, what are some of the policy issues that we'd like to tackle, and evaluating whether 1332 is a vehicle to tackle those issues. So that kind of thinking is a lot of what has fed into this set of slides I'm going to be reviewing with you. So as Cindy said, 1332 waivers, the statute and the guidance provide a pretty open field for states to think about innovating in their healthcare coverage landscape, subject to those statutory guardrails. And as we think about, where are the opportunities for innovation, we sort of think about these 4 buckets that we reflect on the slide, and we're going to dive a little bit deeper into a couple of these as we move on. Certainly, states could think about using 1332 perhaps in concert with an 1115 Medicaid waiver to really try to implement far-reaching policy initiatives to really alter the ACA coverage paradigm, that framework that the ACA sets out to do something quite different to meet the needs of a particular state marketplace. And the example we have here, which is the example Cindy referenced earlier, is that a state could think about using 1332 Waiver Authority to fundamentally change the subsidy structure. Whether that's eligibility for subsidies, income eligibility, whether there are particular categories of individuals like pregnant women for whom you might want to give higher subsidies to encourage residents to be enrolled in coverage. Certainly 1332 has been in the mix for those states that are thinking about sort of broader, more comprehensive change in their coverage landscape. On the opposite end of the spectrum are targeted fixes, states that are thinking about and contemplating using 1332 to address very targeted, very specific ACA issues. And we're going to talk about, I think, that the initial set of states that have submitted 1332 applications fall into this category. There are some state-specific targeted fixes that these states are trying to achieve. But the example we have here is a very targeted issue and kind of a wonky technical issue in terms of determining eligibility for insurance affordability programs, which include Medicaid and the Child Health Insurance Program and the ACA tax subsidies, is that Medicaid uses a different income standard, a different FPL standard at certain points in the year than the standard that is used for tax credits. And the issue is that Medicaid agency in a state uses the FPL chart, that table, from the date of its update. So in 2016, the new FPL table came out on January 22nd, and Medicaid agencies started using that new table almost immediately. Marketplaces, on the other hand, don't update and start using sort of the quote-unquote new FPL until the start of an open enrollment period. So for a certain point in the year, for a certain time period in the year, we're using different FPL standards for Medicaid coverage versus tax credits, which can create some problems and certainly some consumer confusion, and in some cases even looping, where Medicaid is saying, based on our chart, you're not eligible, and the marketplace is saying, based on our chart, you're not eligible, and people are falling through the cracks. So if states say, I'm going to fix that, that makes no sense to me, and I'm going to align those standards. The third area are state-specific innovations, things, policy issues or concerns that are really unique to a particular state. You know, if you have a state, for instance, that's a large state or a very diverse state in terms of rural and urban areas, and you have real differentials in premium costs in those states, but tax credits are sort of benchmarked to a standard plan that may be a lower cost plan, that would mean your tax credits wouldn't go very far in those higher premium cost areas. So in a state like that, the state could think about weighting or modifying its subsidies based on different rating regions, different rating areas, average premium cost. And that would be something that would be very state specific. That wouldn't make sense in all states, but it could make sense in a particular state. And finally, sustainability. The other place we see as a real opportunity in some states for 1332 is a chance to try to create a more efficient and sustainable state-based vehicle for consumers to access tax credits. And marketplace sustainability, exchange sustainability is an issue for all states that run their own marketplaces, whether that's a shop or the individual in shop marketplaces. And certainly states are thinking about how can I use 1332 to make that operation more efficient and more sustainable. This is especially true for states with smaller populations and therefore smaller number of people accessing tax credits and coverage through the marketplaces. And one example of how a state could approach sustainability, and we're going to talk a little more specifically about sustainability ideas, is replacing the marketplace altogether with what's called the direct-to-issuer model. And that's where consumers would be able to enroll directly in QHPs and access tax credits through issuers or through web brokers rather than through a standalone marketplace. So as we continue to talk about what's within the realm of possibility for states, it is really important to acknowledge that a state's marketplace model may influence what they're able to do or what they're able to use a 1332 waiver to do. In the guidance that Cindy mentioned, that sub-regulatory guidance, HHS was clear that it would not be able to customize healthcare.gov, at least in the near term. So healthcare.gov is that FFM application, online application site through which people in FFM states submit an application for coverage and to access tax credits if they believe they're tax credit eligible. And HHS has said, we're not going to be able to customize the rules engine in healthcare.gov for all different state programs. So that might constrain a state that said, I really want to do something different on subsidies, for instance. I want to have a different subsidy scale or different eligibility rules, or a different mechanism of covering people if they are tax credit eligible. If the state is relying on the FFM, that would, at least in the near term, based on this guidance from the Obama administration, may be difficult to achieve. That's not to say that in the longer term it won't be possible. I think, the other thing to keep an eye on is if there's a particular initiative or goal that states have with 1332 waivers that, several states have a common interest. HHS might be more likely to modify its rules if they're going to address the needs of several states. But clearly, they're not going to be able to do sort of one-off state tailoring of healthcare.gov to accommodate 1332 proposals. Similarly, Treasury has also said, look, we can't modify tax credit administration or tax administration for state-specific rules, so that if the state wanted to modify tax credits, really the state would have to take on administration of unique state subsidies. Now, you could take the funding that would have otherwise have gone to those federal tax credits and use that funding, but the state would have to be prepared to administer those subsidies because Treasury can't modify its process to do something state-specific. So I think we just, as you think about using 1332, you have to think about what marketplace model your state has and where that may promote or hinder a specific proposal that a state might be contemplating. Cindy spoke a little bit about this idea of coordinating 1332 and 1115 waivers, and this is actually something specific that the statute speaks to, that states are encouraged to coordinate these waivers and Medicare waivers and to think holistically about their health coverage paradigm for people who are eligible for Medicaid, people who are eligible for Medicare, and people who are accessing tax subsidies or purchasing directly with no subsidies private market coverage. And so depending on a state's policy goals, it really may make sense for states to leverage and think about coordinating 1115 and 1332 waivers to make changes and to align and coordinate those programs to make their coverage paradigm make more sense. Some of the ideas where these two waivers could come together include what we think of as smoothing the cost continuum. As Cindy said, consumers who are at the margins of these programs, who are at the top end of the income eligibility for Medicaid at 138, or at 200% of federal poverty level in the marketplace, as they go up the income ladder, they really face cliffs or significant premium and cost sharing increases that come along with relatively minimal income increases. And so certainly states could think about using these two waiver authorities together to try to smooth those cliffs and smooth the cost sharing experience of consumers across the coverage continuum. Purchasing alignment is another area in which we know states are thinking about how they might use these two waiver authorities together, and that might include creating a Medicaid premium assistance program, as Arkansas has done, so that people who are eligible for Medicaid are enrolling in QHPs. So just as people at 139 are enrolling in a QHP, so too are people below that in the Medicaid eligibility group are enrolling in QHPs. Creating a BHP-like program, the Basic Health Program, is another authority under the ACA. States could use a 1332 waiver to create a similar program, perhaps with different eligibility levels, to try to smooth affordability and cost experience of their consumers who are purchasing coverage. Or creating premium subsidy programs. And we can talk a little bit more about states that have used these authorities to supplement federal tax credits with additional state subsidies, or in some cases, state and federally Medicaid funded subsidies on top of those tax credits. And finally, eligibility and enrollment alignment. So aligning those rules by which people are determined eligible for participation in Medicaid or in tax credits, and that FPL alignment, that FPL standard alignment that I just talked about, is sort of one of those ways in which states could think about aligning. And in terms of enrollment, rules related to how people select and enroll in a health plan, aligning that experience across Medicaid and QHPs. So these are all ways in which states could think about, or broad areas in which states could think about aligning 1332 and 1115 waivers. So I'm going to dive a little bit deeper into the example of smoothing the cost continuum. And this is an example based on New York, which has basically endeavored to make more affordable, to smooth costs for individuals up to 150% of the federal poverty level by implementing a basic health program under the ACA. And you'll see that they essentially now Medicaid and their basic health program, so up to 150% of the federal poverty level. Essentially, they've eliminated that cliff that consumers would otherwise have faced at that seam between these two programs. States could use 1332 and 1115 to create similar alignment between their Medicaid programs and QHP coverage. They could endeavor to achieve that smoothing at this level from the sort of Medicaid, right above the Medicaid income level, or at higher income breaks for people at 200 or 250% of the FPL, or even higher at 400% of the federal poverty level. So what New York has done through Basic Health Program Authority, states could use 1332 to achieve for a similar population or a different eligibility group. States could also, as I mentioned, use 1332 and 1115 to increase sustainability of their marketplaces. So using 1332 authority, states could what we call go lean on their operations. They could replace their exchange with this direct-to-issuer model. They could enter into a partnership with web brokers to promote web brokers as the vehicle through which individuals apply for tax subsidies and enroll in QHP coverage. They could seek to eliminate their shop or rely on the FFM shop program. And in fact, that last item, relying on the FFM, wouldn't require a 1332, but these other proposals would. And all of those are ways in which they could reduce the costs of operating a marketplace in the state. At the same time, states could use 1115 Waiver Authority to implement a Medicaid premium assistance program for QHPs, like Arkansas and New Hampshire have done through their 1115 waivers to enroll Medicaid-eligible individuals in QHPs. What that does is that increases the number of covered lives in the marketplace. It increases the risk pool in the marketplace to good effect in both of those states. And so it improves the size and the sustainability of the marketplace. States could also seek 1332 authority to allow state employees to purchase QHPs through the marketplace. So again, increasing the number of covered lives, improving sustainability. So this slide really reflects sort of a mix of proposals that would be achieved using 1332 and 1115, all with the goal of, would have other good effects in the marketplace, but certainly would have a positive effect in terms of increasing sustainability of the marketplace. So as our last set of slides here, we're going to talk a little bit about so what is actually going on in states. We've talked a lot about, in theory, what could states do and how could they be thinking about this waiver authority. And so now we're going to spend a little bit of time on what are states doing? How are they leveraging the authority? So there were 3 states that have submitted applications or requests for 1332 waivers to date: Hawaii, Massachusetts, and Vermont. We would characterize all 3 of these proposals as targeted waiver requests, and they're all targeted to those states' small group markets, and essentially they're designed to preserve small group market design or features of these states' small group markets that were in place before the ACA was passed. Each of these states, I believe, has had permissions to maintain these features of their small group markets since the implementation of the ACA, and now they have 1332 waiver applications in to make permanent those sort of unique structure of their small group markets, so that they don't have to sort of shift to meet the ACA rules. So in Hawaii, their proposal is to preserve their pre-ACA employer mandate that's been in place to great success since 1974, and is in fact, more sweeping than the ACA's proposal. In Massachusetts, had merged its individual and small group markets and proposes to preserve certain features of that small group market to avoid disruption that state has said would ensue if they had to transition their small group market to meet ACA rules. And Vermont had in place, prior to the shop requirement under the ACA, a direct enrollment process for the small employer market through insurers that has worked very well and to the satisfaction of employees and employers and the state. And so they're seeking to waive the requirement that they transition that legacy program to a shop web portal. And in terms of what's happening in other states, there's a mixed bag out there. Certainly, there are some states that determined that they needed to get specific legislation passed to enable them to pursue a 1332 waiver, even if they don't yet have specific proposals attached to a particular waiver request. HHS has said and the statute has said you have to have the authority, the state has to show that they have the authority to seek the waiver. So certainly there's been some of that activity going on. We highlight for you 3 states here. The first, Ohio, passed legislation in 2015 which authorized the insurance agency to submit a 1332 waiver to eliminate the employer and individual insurance market mandates in the state and establish a sort of state-specific system that provides access to affordable health insurance coverage. Minnesota is a state we know a lot about because we've worked with Minnesota. There's a lot of activity going on in Minnesota with regard to a potential 1332 application. The governor and legislature created a task force on healthcare financing that met over a 6-month plus period of time to consider potential policy reforms in the state and to consider specifically where those reforms might require a 1332 waiver. The task force issued a report, that's a publicly available report that includes a number of recommendations that would require the state to pursue a 1332. And those really range the spectrum from the targeted to the more comprehensive proposals. Additionally, in its last session, the Minnesota legislature considered, and this is still a live bill, that would allow essentially a public option type product to be sold on the marketplace to individuals who are subsidy eligible. And that proposal would also require a 1332 waiver. And Rhode Island also in 2015 adopted legislation that authorized the state to pursue strategies to modify and reform its healthcare coverage paradigm using 1332 waivers. And interestingly, Rhode Island clearly is thinking about the sustainability issue. Rhode Island is a small state, and that legislation specifically referenced waivers that would allow the state marketplace to negotiate and perhaps purchase services from other partnering states. So clearly, at least at the time the legislation was passed, part of Rhode Island's frame of thinking was policy solutions that would promote and improve sustainability of the state's marketplace. So 3, very different states thinking about using 1332 in very different ways, and we hope demonstrates to use sort of the range of opportunities that are available to states as they're thinking about their policy goals with 1332. So I'm going to pause now. Cindy, I don't know if you have anything else you wanted to chime in with on the state-specific examples, and I also think we can go to questions.
I think questions would be great. Thank you, Penny.
Yeah, thank you both. That was very helpful. We do have a couple of questions that have come in from participants. One of them is whether or not the decision, when a state submits this application, whether the decision from Treasury and the HHS is a joint decision or whether it's handed down as 2 separate decisions.
I can jump in on that. Excuse me. The process is contemplated as a coordinated process. So it's one application. HHS has set up a site for receiving applications, and then the rules say it will be shared with Treasury, and Treasury and HHS will review the application together and provide one decision. So you don't have to shop it around to 2 different departments separately. They will coordinate in terms of both receiving and reviewing and issuing a decision.
And Cindy, if I could just chime in, certainly what we know about the experiences of the states that have submitted applications, it has been an integrated process. I will say because 1332 was a new authority, I think there's still a lot to learn, both at the federal government and at the state level, about how that process is going to work and how it will unfold. We know a lot about 1115, and that's a very sort of structured and well understood process. I think there are still some, open questions about how the 1332 process will work. but I agree with Cindy that it's integrated.
Yeah, and let me just add one more thing about the process that we didn't mention. It does require the statute and the regulations require a public comment process, a public notice and comment process. That's similar to what's required to do a comprehensive Medicaid waiver under Section 1115. So before you submit to the federal government, there's a process at the state level to assure that there's been some local notice and input. And you know, I would totally agree with Patty. It's as you're hearing from this webinar, it's a complicated set of issues, both in terms of what you might be able to waive, how the guardrails factor in, and how they get how the different components of the guardrails get calculated, and it's new to everybody. It's new to states, and it is new to the federal government. So if you're you can probably thank your friends in Hawaii and Vermont and Massachusetts for breaking ground and getting the feds accustomed to thinking through some questions, although every waiver that we're going to see for a while will really be, I'm sure, raising some new questions for everybody.
Great. Okay, and we have a question here regarding if a state were to use a 1332 waiver to waive the large employer mandate, it would certainly increase the federal deficit. So if so, how would it get approved?
So I can start on that one. Yes, by itself, with sort of not embedded in a broader policy proposal, that proposal would increase the deficit and probably would not meet that guardrail. So I think, you know, a state contemplating a proposal like that would have to have some counterbalance. And, you know, whether that were, as I think was being contemplated at one time in Vermont, whether that were to say, you know, we're not going to have a traditional employer mandate, we're going to have a pay or play, or employers are going to have to contribute to a universal coverage system or a public option type model in our state. There would have to be some counterbalance that the state would have to present to say, and the way in which we're not going to increase the deficit, and we're not going to impact the number of people, or we're going to be covering at least the same number of people, and we're going to meet the affordability guardrail. You know, that would have to be embedded with a broader policy proposal.
And I would just add that I think that the question underscores the point that if a state is thinking about a very broad 1332, really looking to eliminate or modify one of the key provisions in the Affordable Care Act, the individual mandate, the employer requirement, it's likely not to be approved unless it is part of a broader strategy for redesigning how health coverage is provided in that state. And so the different pieces would fit together, not just to meet the guardrails, but really to make sure that at the end of the day, coverage wasn't diluted. And again, 1332 is not an individual opportunity for states to simply eliminate the coverage or modify coverage that's available, but to do it very differently and to do it in their own way. So particularly those more sweeping changes need to be part of a broader state strategy for how a state decides it wants to proceed with coverage.
Okay, and one question that came in is regarding whether any entity other than a legislature or state executive can use a 1332 waiver, such as a multi-state application or including cities in the application.
Well, I can start on that. I don't know, and Patty, you should jump in. The state is the entity that asks for a 1332, And as been noted, with approval from the state legislature, so there needs to be legislation in support of that. That doesn't necessarily mean that it couldn't be sub-state or that it couldn't be multi-state. It just, the application needs to come from the state. I actually have a hard time thinking about how 1332 would work sub-state, but Patty might have some great ideas on that. I could imagine a multi-state, but I think in that situation, technically, you would probably have each of the states involved submit their application, albeit they could be, very closely linked. So, Patty, any thoughts on the sub-state?
Not immediately. I could definitely see a sort of city-based initiative as part of a broader coverage proposal that a state might make. I'm just at this, I'd love to think more about it actually, but at this moment, it's hard to envision sort of a standalone sub-state application.
Right.
Or, that was only sort of targeted in a sub-state area.
Right. But either way, the state would have to make the request. So in 1115 land, right, the Medicaid waivers, there are sub-state waivers are not uncommon over the years in 1115 history, but it is always the state itself that makes the application, even if the waiver would pertain only to a city or a region or county in a state.
Okay, thank you. And as a final question, is there a cutoff deadline for starting or filing a 1332 waiver?
It's rolling. There isn't a deadline. There isn't a cutoff. And, I think it also isn't a one-shot deal. I think a state could come in as, I suspect the 3 states that have come in with narrow, targeted, there are some things we need to address now, and could come in later with a broader, more expansive waiver request at a later time.
Great. Okay. Well, thank you all. This has been very helpful. And on behalf of NCSL, I want to thank you both, and also thank you for the support from the Health Resources and Services Administration for putting on this webinar. I wanted to say there are some additional 1332 resources on the NCSL website. If you search for 1332 waivers, there is a list of the 15 states and the legislation that has been introduced to date to kickstart the process for those states. These 2 webinars, Part 1 and Part 2, will be posted online in a few days. It takes about a week, but please look for those on the NCSL website, and thank you so much for joining us, everyone.
Thank you. That does conclude today's webinar. You may disconnect your lines at this time and have a great day.